Hello, everyone, and welcome to the AC Forum's webinar. Today's topic is a great one. We have aspirin de-prescribing and PPI prescribing, gastroprotection among patients taking oral anticoagulants. We have two guest speakers today, both from the University of Michigan, Jacob Kurlander and Jordan Schaefer. Next slide, please. So we have Jacob Kurlander, who's assistant professor of internal medicine and division of gastroenterology at University of Michigan. We have Dr. Jordan Schaefer, who's associate professor of internal medicine and division of hematology and oncology at University of Michigan. And I will be moderating this along with my co-moderator, Andrea and Beek. Both of us are board of directors. I'm from the VA Salt Lake City and healthcare system, Salt Lake City, Utah. And Andrea is from Visalia Medical Clinic in California. Next slide. All right, I will take it away, speakers. Thank you.
Good afternoon, everyone. Thank you for the opportunity to present. So today we'll be covering the prevalence and potential risks of anticoagulant antiplatelet therapy, talk some about candidates for aspirin de-prescribing. We'll talk about some of the risks and benefits of gastroprotection with proton pump inhibitors, and talk about some intervention strategies for people who want to bring aspirin de-prescribing to their practice, and along with increasing usage of gastroprotection. So combination therapy with an oral anticoagulant and an antiplatelet agent is very common in clinical practice. The figures shown here on the left are patients on warfarin and aspirin, and to the right are patients on direct oral anticoagulants and aspirin, followed by the Michigan Anticoagulation Quality Improvement Initiative, which represents thousands of patients in this study. And you'll see that about a third of patients are on combination therapy. And this didn't really change much over time that these patients were followed, suggesting a need for active intervention. In fact, in the literature, this 1/3 rate has been pretty stable dating back many years. Again, suggesting that this is an overlooked problem. When we take a closer look at these patients, and here is a study by Dr. Kurlander of over 3,000 patients. We found that about 80% had an opportunity to improve their overall bleeding risk profile. 14% didn't have an indication for antiplatelet therapy, but were on PPI. 30% had no indication for an antiplatelet therapy, but were on it, but were not on a PPI. And then over a third of patients were on combination therapy with an anticoagulant antiplatelet, but not on a PPI, potentially suggesting an opportunity for quality improvement. So, with combination therapy, it's always a question of risk versus reward. And so when we take a look at patients that are on aspirin and warfarin, again, without a strong indication for such therapy, without, for example, recent, myocardial infarction with percutaneous coronary intervention, we see that there's a number needed to harm of about 36 to 91 for the outcome of major bleeding. That suggesting that for every 30 to 90 patients treated with combination therapy unnecessarily, you're increasing the risk of major bleeding by one extra event. And again, here we have a study done out of Mackey for patients on warfarin and aspirin, represented by the blue line, compared to warfarin monotherapy, represented by the yellow line. If you look out at 3 years, you see that there's over a 1% difference in the rate of major bleeding. So while the magnitude of difference is, small, this is significant considering the number of people on combination therapy, with many people, on aspirin unnecessarily. In the same study, we didn't show that these patients were deriving any thrombotic benefit, and these were patients with atrial fibrillation or venous thromboembolic disease on warfarin. In the literature, it's often cited that there's combination therapy is associated with a twofold risk of major bleeding. Similar findings are largely in place with the direct oral anticoagulants. When we studied this through the Michigan Anticoagulation Quality Improvement Initiative, again, we see increased bleeding with this lightly shaded, bar graph with combination therapy with DOAC and aspirin compared to DOAC alone. Other studies have, similarly reported a number needed to harm around 125. And again, this select patient population, which at the time was patients without a history of heart valve replacement or recent myocardial infarction, didn't derive any apparent antithrombotic benefit from combination treatment. So, thinking about combination therapy, we kind of look at, who are the people that might, we're trying to balance bleeding and clotting. And so trying to think about, the two ends are pretty straightforward. There are some select indications for combination therapy where these studies have shown a net benefit, for thrombosis reduction compared to bleeding risk. But a lot of patients are to the right of this diagram here, where there's a net harm, where, they're kind of low clotting risk, low to moderate clotting risk and high bleeding risk, or patients at a standard bleeding risk with low to moderate thrombotic, risk that don't have an indication. Often this is, people on aspirin for primary prevention that then develop an indication for oral anticoagulation, and the aspirin gets overlooked and never gets stopped. And the studies have, pretty consistently shown a net harm, for these patients. And guidelines, suggest that, in this group, we can often consider de-prescribing. And there's some patients where there's some uncertainty in the middle. And so again, ongoing research is needed. And then clinical follow-up will sometimes, dictate, whether a patient should be in one of these categories. So, there's this slide here is not comprehensive, but has some general considerations. And again, it's on the spectrum. Emphasize the right side. For patients on oral anticoagulation, primary prevention aspirin is not routinely indicated, and aspirin for analgesia pain purposes is generally not indicated. There's some other, groups in the middle that there, it can be considered. For example, antiphospholipid antibody syndrome, patients with high vascular risk with secondary prevention with an indication for anticoagulation. But again, this is also being, challenged. And then, combination therapy is indicated after percutaneous coronary intervention with an indication for anticoagulation and with certain devices, graft stents. Also, we'll briefly cover, which has been separately covered, the COMPASS trial, which looks at a low dose of oral anticoagulation with antiplatelet therapy in select high-risk patients. So again, the overall, with any patient you're seeing on oral anticoagulation, you want to try to optimize bleed risk. So that can be looking at, renal and hepatic function, keeping blood pressure well controlled, treating iron deficiency anemia or, thrombocytopenia as appropriate, limiting use of alcohol and NSAIDs, talk about fall risk, sometimes physical therapy and optimizing eyesight, things like that. Always trying to improve anticoagulate dosing and quality. And then, for some patients, there's a role for gastrointestinal prophylaxis to try, for these patients that do have a higher bleed risk, what can we do to try to reduce that, especially the patients that have an indication for combination therapy. So shift to Dr. Kurlander to kind of take over.
Thanks, Jordan. Yes, I'll be talking about the risks and benefits of gastroprotection and how to really choose that subset of patients who are anticoagulated who are going to really truly benefit from PPIs. And we know a lot about the risk factors for upper GI bleeding, and most of them are really pharmacologic. So aspirin, oral anticoagulants, high-dose corticosteroids, and NSAIDs all roughly double the risk of upper GI bleeding. And when you combine these medications, the risk is additive. So a patient on an oral anticoagulant plus aspirin, the relative risk is 3.6. Another factor to really think a lot about is age. So we know that for every decade of life over age 60, the risk of upper GI bleeding approximately doubles. So for a patient age 70 to 79 compared to a patient in his 50s, his or her 50s, the relative risk is 4.5. So there have been many trials looking at gastroprotective drugs to prevent upper GI bleeding, dyspepsia, perforation, that sort of thing, specifically in patients who are on antiplatelet and NSAID drugs. These drugs we know, because of their mechanism, increase the risk of mucosal erosions and ulceration. So in the PPI, since PPIs have been developed, there have been 18 trials of those drugs, and the odds ratio is 0.21. Again, specifically in patients who are on antiplatelet drugs and NSAIDs, so really quite effective. You also note that H2 receptor antagonists are also effective, but not quite to the same degree as PPIs. So they have an odds ratio of 0.49. We know actually less about the effect of PPIs in patients who are on anticoagulants. So in general, anticoagulated patients were not in these previous trials of PPI gastroprotective drugs. But we did do a systematic review and meta-analysis looking at this question: how effective are PPIs for prevention of upper GI bleeding in anticoagulated patients, including both warfarin and patients on DOACs? And we found 4 observational studies and then 2 groups from the COMPASS trial that we could include. And here in the forest plot, you can see that the pooled estimate shows a risk ratio of 0.67. But one thing to note is that this is sort of the average treatment effect across the population. So it includes both patients who are at low risk and those at high risk for upper GI bleeding. The 2 rows here associated with the COMPASS study, you'll note, did not show an effect of the PPIs on upper GI bleeding, and I'll come back to that and why that may have been. So in that last slide, we were looking a little bit about the average treatment effect across the anticoagulated population. So one question is, which patients should we really be targeting, and does the benefit vary by risk? And this is a question that Wayne Ray looked at in this study published in 2018 in JAMA. So they used Medicare data to create a risk prediction score for upper GI bleeding using about 70 variables in Medicare. And using this risk prediction score, they were able to break patients out into 10 deciles of risk. So in this graph on the y-axis, you see the hospitalizations for upper GI bleeding per 10,000 person years, and then along the x-axis, the different deciles of risk. And there's a statistically significant effect of the PPIs in all but the lowest decile, but it only really appears to be probably clinically significant in these 3 highest deciles of risk in this red box. Oops, let me go back there, slides. So in deciles 3 through 6, the number needed to treat is about 500. For the 8th decile, it's about 200. And in the highest decile, the number needed to treat for 1 upper GI bleed in a year is 84. Unfortunately, this internally derived risk score that Wayne Ray created there was never externally validated, and we don't know the parameters used to estimate kind of a specific score for a patient you see in clinic. So the question is, what are general risk factors that we should be acting upon? And the same group actually looked at that in a prior study in patients who were treated with warfarin. These are, again, patients who were on Medicare and Medicaid, in this case, only on warfarin. And in this graph, they show the upper GI bleeding rate, again, per 10,000 person years. And then on the x-axis, they broke it out by patients who are on an antiplatelet drug or an NSAID and those who were not. And so you can see that in the folks who were not on an antiplatelet or an NSAID drug, the hazard ratio crossed 1, so really no effect there. But in those folks who were on an antiplatelet or NSAID drug, the hazard ratio was 0.55, corresponding to a number needed to treat of 77. So this brings me back to the COMPASS trial, the rows on that forest plot before where PPIs appeared to have no effect. So this is really the only randomized trial of PPIs in patients who are using anticoagulants. But there are a few things to note about this trial that I think should give us pause about its generalizability to patients on full dose anticoagulation. So first of all, the patients in COMPASS were on low dose rivaroxaban with or without aspirin. So these were not patients on really therapeutic anticoagulation. Another factor to consider is that the patients, the criteria excluded patients with a clinical need for PPI. So patients who were known to need PPI gastroprotection or who were thought to be at high risk for upper GI bleeding were excluded from this trial. And they also excluded patients who were on dual antiplatelet therapy or on like a therapeutic anticoagulation. And their outcome was a composite of both overt upper GI bleeding, occult GI bleeding, and symptomatic peptic ulcer disease. So for their primary efficacy outcome, their hazard ratio was 0.88 with pantoprazole compared to placebo. So no effect there. But you can see here that the rates of this composite outcome are actually quite low, lower than you were seeing with the trial or the observational studies I showed before. And this really underscores that this was a study of the effect of PPIs in low-risk patients, similar to that study a couple slides ago of patients on warfarin who were not on aspirin or an NSAID. So there are a number of recommendations, published by GI and cardiology societies about which anticoagulated patients should be on a PPI. And really, there are three main groups to think about. Patients who are on an anticoagulant plus an antiplatelet medication, either P2Y12 or aspirin, on an anticoagulation plus an NSAID, or on anticoagulation with a history of prior upper GI bleeding. And the references are here at the bottom. For this last group, you should also probably confirm that the patient had been tested and treated for H. pylori, and we can talk a little bit more about that if there are questions afterwards. So these are the general recommendations, but there are, as I showed before, many risk factors for upper GI bleeding that are not taken into account here. So I think there's also room for clinical discretion in choosing other patients who might benefit. So one mnemonic just to keep in mind when you're identifying patients appropriate for PPI gastroprotection is TUNA-2. So patients who have any two of the following risk factors: thienopyridine, an ulcer history, NSAID, aspirin, or anticoagulant. And this doesn't just apply to patients on anticoagulants, but really a patient on an NSAID and aspirin, for example, is recommended for PPI gastroprotection, or a patient with an ulcer history in any of these medications. Hopefully mnemonic will help keep that in mind. So, when we're prescribing PPIs, or when a patient who's on a PPI comes to clinic, a question we often hear about is, what are the risks of side effects? A question that so often comes up because these are drugs that are so common, and when these observational studies come out suggesting adverse effects, they get a lot of play in the media. So PPIs have been associated with adverse effects potentially in every organ system. Among them are dementia, community-acquired pneumonia, osteoporosis, bone fractures, diarrhea. And those are really, most of those studies are almost exclusively observational studies. But fortunately, the COMPASS study, the same study we were talking about a little bit earlier, had a sub-study where they looked at the effect of and the safety of pantoprazole across the 3 years of the study. So this is really kind of the highest quality type study we could use to look at effects of PPIs. And they looked at over a dozen of these potential PPI adverse effects and had over 50,000 years of patient follow-up with monitoring of these adverse effects every 6 months. So across these 12 different potential adverse effects, the only one where they found a statistically significant increase in the risk was for enteric infections, where the odds ratio is 1.33. So that corresponds to a number needed to harm of about 300 over the course of 3 years. But they didn't see differences in any other outcome groups. And I think people, are looking at this and saying that this is, basically the strongest possible design, showing that if you start kind of a diverse group of patients on a PPI and follow them up for a few years, there's really only an increased risk of this enteric infection. And I should note that these are not C. diff infections; these are non-C. diff enteric infections, like Klebsiella. So what are we to make then of all these observational studies that show that PPIs are associated with all these conditions in other organ systems? Well, we can apply sort of known epidemiologic principles to assess the strength of the association and whether it meets criteria for causation. So Sir Austin Bradford Hill, an epidemiologist in Britain, actually the first person to have done a randomized trial, proposed these 9 criteria, which are still commonly used and kind of cited in epidemiology textbooks. So I'll just go over a couple of them. So the strength of the association is an important thing to take into account, whether it's less than 0.3 or greater than 3, whether there's consistent finding of an association, temporality. So in studies, whether the exposure to the drug consistently precedes the outcome, gradient effect. So whether a higher dose of PPI is associated with a higher risk of the outcome, and experimental data. So having a randomized trial which confirms the association. And so here I'm showing you a heat map of whether the criteria are met. These sort of along the y-axis, these 9 criteria for determining causation, and 17 of these adverse effects which have been statistically associated with PPIs. And as you can see, green is kind of yes, the criteria is met. Red is no, and orange is that it's weak or possibly met. So for the most part, the only criteria that's consistently met is that of a temporality. In these studies, they're pretty consistent in showing that the PPI did come before the pneumonia or the C. diff. But looking down the columns, the ones where we have the strongest evidence of true causation are severe hypomagnesemia, funded gland polyps. So these are funded gland polyps are non-cancerous, sort of benign polyps that grow in the setting of hypergastrinemia, which is caused by PPIs, and then enteric infections, which we already spoke about. So I think these are probably the 3 conditions where we have the best evidence of some real causation from PPIs. So this brings us to the question of how to intervene to kind of close this gap. We know that only about 1/3 of patients who are on aspirin and an anticoagulant are on a PPI. And we've done interviews at the University of Michigan, sort of looking at what the barriers are to PPI gastro-prescribing. And we focused on primary care providers, cardiologists, and vascular surgeons who often are treating these patients who are on combinations of drugs that increase their risk. And three barriers really stood out. So the first is knowledge. I think there's kind of low knowledge of the guidelines, appropriate patient selection. And that's kind of common across all 3 of these specialties that we looked at. They don't have systematic strategies for identifying these patients. So really it's got to strike them in the spur of the moment when they're seeing these patients in clinic. They're generally not alerts or best practice advisories that are popping up on this. This is kind of a low priority topic, so it's not something that patients are bringing up. And it can really fall by the wayside when patients are coming into clinic with multiple symptomatic complaints. And then the last one is ownership. So, for a patient who's seeing multiple specialists, a PCP, a cardiologist, and maybe even a surgeon, someone's got to take this on and view it as their own responsibility. But we weren't finding that any of these specialists necessarily took that approach. And these do actually vary by specialty. I don't want to throw surgeons under the bus, but they told us pretty explicitly that they're not in the business of doing medication management and providing medication refills. So they almost exclusively will defer the issue of gastroprotection to a primary care provider. So based on these interviews, we did devise sort of an intervention at the University of Michigan that we tested in a trial, the Anticoagulation with Enhanced GI Safety Trial, or AEGIS. And this was a trial that we conducted in the anticoagulation clinic with the intervention administered by the nurses there. So the intervention consisted of basically a workbench report or dashboard that identified these patients who met criteria for PPI gastroprotection. The nurses then sent an encounter in the EPIC EHR to the clinicians that identified these patients as high risk, and then suggested that they either discontinue antiplatelet drug if not necessary or start a PPI. The nurses also offered to communicate recommendations to the patient and to enter the order for the PPI if that was the decision. And in this trial, we targeted the cardiologist first as the recipient of these messages. So for patients who saw multiple clinicians at U of M, if there was a cardiologist, that was the first person who would receive the message, because they seemed to be the most fitting person to decide on antiplatelet therapy. Next, we would send it to the PCP if there was one, and then another specialist only as kind of like a last resort. So we evaluated this with a cluster randomized design, and we had a waitlist control group. So basically, we had a group of patients who were going to get this in an initial rollout, and a waitlist control group that would get it as a second phase. And we included all patients on warfarin and an antiplatelet drug, excluding basically just those folks who had a heart transplant or who had an LVAD. And our primary endpoint was the proportion of patients who either stopped their antiplatelet drug or initiated a PPI based on self-report at 7 weeks. So we included 121 clinicians and 220 patients. This is a snapshot of the message that we sent. So again, identifies the patient as high risk, notes the guidelines recommending some form of gastroprotection here, and then a link to a guidance statement that helps the docs make a decision about whether to continue or discontinue the antiplatelet drug. Here's a snapshot of that guidance summary, which was based on a publication by Kumbani, the ACC sort of expert decision pathway. And what we found at 7 weeks on these phone calls was that there was a significant effect. So in the intervention group, more than 60% had medication optimization, and in the control group, it was about 21%. Those folks in the control group, we're still analyzing this data, but the folks in the control group who appeared to have medication optimization, it appears to be that these were actually patients who didn't qualify for the trial in the beginning, so they were actually on a PPI to start or not using aspirin in the very beginning. So the odds ratio was 8.75. And if we look in the electronic health record at recommendations to make a medication change, the odds ratio was actually 20. So it was quite effective, but didn't always translate through to patients making a medication change. We've also done a pilot study here where we developed and tested a patient activation guide. So the idea here was to create a booklet that can be sent through the portal or by mail to patients that would encourage them to discuss with their docs making one of these two medication changes to decrease their risk of upper GI bleeding. This was specifically designed for patients on warfarin and an antiplatelet drug. And what we learned in this pilot is that this was basically a total failure. We interviewed 16 patients who got mailed this guide or received it through the portal, and very few of them, completely read it or recalled it when we spoke to them on the phone, and none of them spoke to their docs based on the guide. And there are a number of reasons which we sort of elucidated in interviews with the patients, but just a couple of them are that patients seem to be inundated now with mailings like this, especially patients who might be in an anticoag clinic who are getting a lot of safety notices and that sort of thing from the clinic. And trust also seemed to be kind of a moderator of this effect. So a lot of these clinicians have a high degree of trust in their docs, and they felt like if there were a medication change that would make them safer, their docs would be thinking about it. So I'll hand this back over to Jordan, who can talk a little bit about what's been done in Mackie.
All right, thank you, Jacob. So the Michigan Anticoagulation Quality Improvement Initiative is a group of anticoagulation clinics in Michigan that represent both urban and rural practices with patient censuses from the hundreds to thousands that care for a diverse group of patients and have a shared goal with regular meetings to try to improve anticoagulation and antithrombotic therapy delivery. And so, we had done these two, kind of observational studies looking at our patients and showed, a lot of people are on anticoagulation and antiplatelet therapy without a good reason for the antiplatelet therapy. And over years of, study with propensity matched, extensive registry data, these patients were bleeding more and not getting any kind of benefit. So understandably, there was a desire from Mackie to try to reduce unnecessary aspirin use. And so, I'll kind of use this slide. It's a busy slide, but we'll go through, the approach, starting with this flow chart on the top. The first step, for an intervention to try to reduce, unnecessary aspirin use or high-risk aspirin use was to identify patients on warfarin, followed by the anticoagulation clinic for atrial fibrillation or venous thromboembolic disease. And, each center used their different strategies to try to identify patients. Some used the electronic health record, some, directly asked patients. but found patients on aspirin. And then they went through their chart and looked for possible reasons, such as, and each center was able to adapt the, possible reasons to their own, practice, but, things included any, we started with people with really, no apparent reason for the aspirin. So any history of coronary artery disease, such as myocardial infarction, CABG, percutaneous coronary intervention, antiphospholipid antibody syndrome, heart transplant, stroke, mechanical heart valve at the time. This was, a couple years ago that this started, ventricular assist device, or even peripheral arterial disease. And if it wasn't clear why they were on combination therapy, a message similar to what Jacob shared was sent to their, managing doctor to ask, do they need to be on aspirin or not? And sometimes, the provider might not even be aware that their patient is on combination therapy, given that aspirin's over the counter. And so then the doctor would make a recommendation in conjunction with their patients, and then the anticoagulation clinic was able to facilitate, that recommendation. This is now this intervention's been in place for about 4 years, but this is our data at 2 years. Again, you see that historical mean use of combination therapy. And then, we did see some decline in combination therapy use over the 2 years prior to our intervention. And each site had a different intervention start date, but overall, about 2 years post-intervention, the mean rate of combination therapy was 15.7%, and you see it approaching, 10% here at the end of this study. And we found that, reducing aspirin overall was associated with less bleeding. These dots represent the percent of patients with an event, in this case, major bleeding, as defined by the ISTH per month. And this is pre and post intervention, and we see that there is a overall decline post intervention in bleeding outcomes. The citation for this, more detailed paper is below. So quickly, for people looking to do this at home or at their home institution, as far as how go about this, first step is identifying the patients. For warfarin treated patients, this can be through an anticoagulation clinic if they're followed by such. For patients on a DOAC, other strategies might be needed. Identifying the aspirin use, we've done some other studies that actually shows the electronic health record is pretty good at identifying aspirin use, at least at in our center review, fairly good sensitivity and specificity, but not perfect. And then, engaging the managing provider, encouraging, shared decision-making as appropriate. And, given, involvement of anticoagulation experts, through AC Forum and through, through the various centers, there's an opportunity to facilitate that care coordination and involve, oftentimes these patients are followed by, multiple providers like hematology, cardiology, vascular surgery, coordinate, between doctors, who's taking control of the aspirin, who's managing it, should it be, continued or discontinued. Documenting this process and with the communicating with the patient as appropriate. And, for patients that are at high bleed risk and aren't on gastrointestinal prophylaxis, as Jacob shared, consideration of adding gastrointestinal prophylaxis at that time. So I'd like to thank everyone from the Michigan Anticoagulation Quality Improvement Initiative that was involved in the data behind our aspirin de-prescribing studies and the work from Dr. Kurlander. And I'll go ahead and we can take questions.
Actually, if you could share your slides one more time, Jordan. I had a couple of slides I want to go through before we open up to questions. A reminder, however, I should have mentioned this at the top. Please make sure and list any questions in the Q&A box, not the comments box. We've got a number of questions coming in, and we have some that were submitted prior to the webinar. Excellent presentation. Thank you both. Really important topic. I also wanted to highlight that the AC Forum Innovation Circle actually did a QI project getting at aspirin de-prescribing. So as a reminder for those that don't know, the AC Forum Innovation Circle is a subset of and really an exclusive program of the AC Forum Centers of Excellence practices. So those practices that have been identified as centers of excellence are invited to join the Innovation Circle. about 111 members currently, and the group meets every other month for peer-to-peer presentations and discussions. Really the idea being these are the innovators and they should be sharing the ideas that they have with other innovators to help spread. And so they did a project looking at this based on Mackey's research that was presented here. 16 of the Innovation Circle members or practices participated in a joint effort to really get at this issue of de-prescribing. Participating members were asked to evaluate the need of their respective institutions and were given the option to determine their own parameters for addressing inappropriate aspirin use. Data was then extracted at each institution from their electronic health record and reported via REDCap to Michigan Medicine for evaluation, and then Michigan Medicine blinded and shared the information with the group to monitor project progression. So if you go to the next slide. So this was actually presented as an abstract at the AC Forum conference meeting here this month. They found that despite very low numbers of target patients, and I think that's actually really key. When you take centers of excellence, innovative practices, this is not new to them. And they actually started with baseline levels of concomitant aspirin use that was significantly less than, let's say, 1/3 or so that you will present earlier in this presentation. 7 groups were able to significantly reduce the use of concomitant aspirin within 6 months of participation. This is really a great example of a project when you get like-minded folks together targeting something, they can really achieve a great deal. Next slide. So again, I want to thank Jacob Kurlander and Jordan Schaefer for these presentations. And now at this time, we'll come off the slides on the camera. Andrea Van Beek and myself will moderate some discussion. And really, first off, this topic, if we go to the 30,000-foot view really of aspirin use, and you start there, forget about anticoagulation for a minute, the field has really shifted on aspirin use. And I think that aspirin has been seen as this kind of like magic pill that does a great deal. And historically, I think that that's been true for cardiovascular risk. I think that that is changing. If you look at guidelines that have shifted over several years about where's their net benefit versus net harm in the aging population, for example, primary prevention is not, take an aspirin a day and keep the doctor away like it used to be. And even if you look at the shifting technologies in those patients who do have CAD, who undergo PCI, for example, even there, the aggression with which we need to use antiplatelet therapy is backed off a bit, with some of their timelines changing, with better stents, with stents that are less likely to remain exposed after a significant period of time. So it's important to understand that in general, aspirin is not the magic drug that it was once thought to be. So if you start from there and then you jump into patients who are orally anticoagulated, I think that we look at this a lot of, gee, I don't know, is it okay if I stop the aspirin? When in reality, the question should be, of course I should stop the aspirin. Who are the patients that I shouldn't, right? So I think that we, much like in the early days of DOACs, where we thought, who can I use a DOAC in? We now say, well, really, who can't I use a DOAC in? And that's the way we need to be thinking, I think, about concomitant antiplatelet therapy. So getting at those issues, one of the questions that came through, or actually more of a comment I'll have you folks speak to, is one of the things that didn't come out in this presentation, we saw like number needed to treat, number needed to harm with these therapies. But one thing that gets forgotten is if you have a patient where you're aggressively using antiplatelet therapy and they're anticoagulated and they have a major bleeding event, what actually happens is everything gets stopped. Now, if they're a CAD patient or a recent stent patient, their risk of an MI or acute stent thrombosis goes up. If they're a VTE patient, the risk of VTE goes up. If they're an AFib patient, the risk of stroke goes up. And so I don't know, do you have any idea of how that might play into some of those numbers as numbers needed to treat, because they are numbers needed to harm? They may actually change that.
Yeah, I think that's a good point. And something that I'm surprised at clinically is that, people come in for these major bleeds, and it's really a good, opportunity to take a look at the medication list and see, what really needs to be on, because patients are often excited to de-prescribe aspirin. If you tell them, hey, you don't really need to be on this, it's one less pill you need to take each day. And sometimes we don't see, intervention done even at the time of a major bleed, but it is something we definitely, discuss with patients. In our data, patients were censored, once they had an event, at least for the warfarin and aspirin data. So at the time that, patients contributed data up until the time of an event because of those changes that happen afterwards. So, after a major bleed event, we don't, oftentimes, hopefully, you'd assume that the aspirin was discontinued, or GI prophylaxis was added if it was needed, or the anticoagulation errors were corrected. But we know it doesn't always happen, and so we kind of followed people until events, or for that data. And the other data was aggregate data based on the number of events per month. So we don't have fine level detail about what are happening in that. We get our best data when people are enrolled into our registry, and then we follow what happens to them. But after those events, we might not capture every change that occurs.
Yeah, I think you're right, absolutely right, Arthur, that, in addition to stopping the antithrombotic drugs, these patients are, hospitalized sometimes for a prolonged period of time. And, and some of the studies show that the case fatality rate for a patient with a major upper GI bleed who's anticoagulated is as high as 10%. And those are like 30-day mortality rates. So it's not that these patients are necessarily immediately exsanguinating. It's that they have all this comorbidity associated with hospitalization and things like, discontinuation of their anticoagulation. There's a nice article by Lee, a British group that published this in the Lancet, showing that among patients who've had a stroke while on aspirin, for patients over age 75, the majority with a GI bleed will have either disability or death afterwards. So really, in these older patients, it's not trivial.
Absolutely. So you were talking about this guidance statement. I can't remember who had that in their slide deck, but this guidance statement of when can we discontinue the aspirin, which I think is a really practical thing our membership is interested in. Like who can we discontinue it in? Is that guidance statement readily available, or is that published somewhere that our membership could go to and look for that? Either of you know? Anybody know?
Yeah, I can put the link in there. It's Kumbani, the 2020 the ACC expert consensus decision pathway. And Jordan and I have talked about it. He can give some perspective on sort of like the confidence that they have in making those recommendations. But I'll drop the link in there.
Great.
Yeah, I think that's a good resource, and often some one that's good to look at. There are some select subgroups in there and some kind of nuance to certain subpopulations of it, but I think it's a good resource for people to look at.
What's interesting when we talk about guidance is this isn't new, right? The question of should I use aspirin for primary prevention and anticoagulation therapy is no, and that's not new. That goes way, way back. But even the other place where we know really good answers, so it's kind of funny, if you look back over the last decade or so of anticoagulation and antiplatelet guidance in patients who have CAD, MIs, PCI, there's a lot of things across the different societal guidelines that don't agree, right? But they now align better, but historically they didn't align. But you know what the one thing is that they all agreed on? When a patient has stable CAD, they don't need to be on concomitant aspirin. Now we can argue what stable CAD means, but in general, it means that they haven't had an ACS or an acute or a revascularization within the past year. And some would now argue that in high-risk patients can be pushed back to say 6 months or so. There's some cardiology guidance, their own guidance, that clearly states that. So this guidance about de-prescribing aspirin is not new. An effort to really focus on it may be. Do you have another question lined up for us there, Andrea?
Sure. So a few questions have come in on the Q&A about reasons to give a PPI to a patient, maybe a patient that's not necessarily on an NSAID or aspirin, like just on a DOAC. So like patients, for example, like gastric bypass history, steroid use. Are those patients we should be giving gastroprotection to, or is that a little bit of overkill?
Yeah, I mean, it depends on, with the gastric bypass, we also often see, marginal ulcers and that sort of thing, but they're not the rule. So I wouldn't necessarily think that every patient with gastric bypass would need a PPI. Yeah, I mean, the other thing to attend to is just like, the risk of upper GI bleeding in terms of prior endoscopic findings, erosion, small ulcers, that sort of thing. H. pylori is another risk factor that's been looked into, mainly in the setting of aspirin and NSAIDs. There was just a trial published in Britain, the HEAT trial, that showed that there's a reduced risk of ulcers in patients who are on aspirin. That it seems to go out a few years, but after a number of years, the risk kind of returns to a baseline.
Got it. What about this like intermittent steroid use? If a patient's on a short course of steroids, or say, for example, they're on a longer course of steroids for some reason, is that any indication for gastroprotection?
It's not in the guidelines. High dose steroids really are like a pretty potent risk factor for, upper GI events, like 40 milligrams of prednisone. I think probably not the doses that we use for like RA, 5 milligrams. But that there's not great, evidence, one way or another on that.
Got it.
Excellent, thanks. There's actually a lot of questions that have come in, and I think you really answered some of these in your slide deck. There's been a lot out there about the risk of long-term use of PPI, from vitamin deficiencies to some of the stuff that you mentioned with bacterial overgrowth. And then there's also one question that was submitted online or submitted before about where PPIs fall in the Beers criteria. In addition to that, there's some questions about PPIs and drug-drug interaction with thienopyridines. So can you really speak to what's what with regard to drug interactions with PPIs, to long-term effects of being on PPIs? And Jacob, I think I probably got to throw that one your way.
Yeah, so there are a lot of different recommendations that PPIs should be discontinued. It was included as one of the recommendations from the GI societies in the Choosing Wisely campaign. PPIs are also included in the Beers criteria for patients over 65. But generally, these recommendations do sort of like carve out patients who are high risk for upper GI bleeding. They're certainly not included in the Choosing Wisely recommendations. And there have been a number of sort of like expert consensus documents released by the AGA, the American GI Society, that sort of reinforces that PPI should not be de-prescribed in patients who are using them, appropriately for PPI gastroprotection. We can be pretty confident that in someone who's legitimately high risk for upper GI bleeding, the benefits are going to exceed the risks of these questionable adverse effects. In terms of the interaction with clopidogrel, that's really a controversial topic still. So we have in vitro evidence that PPIs reduce the antiplatelet effect of Plavix, but in meta-analyses, it appears not to have sort of a clinically significant effect on MACE. And in the only randomized trial we have on this topic, which is the Cogent trial, there was no increased risk of MACE, and it in fact decreased upper GI bleeding. So the guidelines are sort of like all over the place when it comes to this topic. Most of them recommend at the very least a patient will talk to their doctor about this before just starting a PPI if they're on Plavix. Some recommend considering use of H2 blocker instead, but you'd have to. The drawback there is that it's less effective, and you'd have to use it at twice daily dosing. So those are kind of the main issues. The other thing to think about is using pantoprazole instead of omeprazole or esomeprazole. Omeprazole and esomeprazole are the ones that have, in theory, the strongest effect in terms of the cytochrome P450 with metabolism of the clopidogrel prodrug. So pantoprazole is you know, if you believe that evidence is probably the safest one to use.
Excellent, thank you.
Yeah, along kind of a similar thread to that, we've gotten several questions about dosage of PPI or H2, like which drug do we use? What dosage do we use? Is there like, when do you need to use pantoprazole BID versus daily? Can you provide a little insight about that?
Yeah, so the PPIs that are sort of approved actually for NSAID gastroprotection are just lansoprazole and esomeprazole, but all of them are really widely used, you know, for preventing upper GI bleeding, and probably most commonly omeprazole because it's the cheapest. It's available over the counter. So a standard dose of omeprazole is the one that's used in many trials. So like omeprazole 20 milligrams daily. The approved dose for lansoprazole is like 15 or 30 milligrams daily. So it doesn't necessarily need to be high dose. The only setting which I would use a high dose is in someone who sort of was like non-responsive to you know, the typical single daily dose.
Got it. And just to add on to that, when would you choose an H2 versus a PPI? Knowing that it's a little bit less effective, but when would you choose that over the PPI?
Yeah, probably in a patient, you know, where they've sort of like proven themselves high risk for some of these adverse effects. So maybe someone who had, you know, is having like recurrent C. diff, in a patient maybe who has concerns about developing those things, you know, these types of adverse effects. I think it's a reasonable discussion to have. And then there are also, you know, very rare, but there are also, you know, some true drug-drug interactions with the PPIs where an H2 blocker would be a good alternative.
Thanks. Jordan, let me throw in your way, because in some of your presentations, you had kind of the consideration for where we should or shouldn't use antiplatelet therapy. And I noticed that you mentioned on-X valves, mechanical valves, and we've had several questions about should we use antiplatelet therapy on top of anticoagulants in patients with mechanical valves. And I know this has changed recently. Can you speak to this?
Yeah, and this, you know, I'm a hematologist, which is has some good and bad to it. So it's fortunately something that I often work in conjunction with our cardiology colleagues. For example, Dr. Jeff Barnes, or who's a member of the AC Forum. So you know, there's been kind of this, as you were mentioning earlier, you know, the 2018, we had these three big, you know, RCTs of the primary prevention aspirin that, you know, raised, you know, increasing concerns. And then at the same time, we were doing our studies of our anticoagulated patients. And then also there's been changes in the guidance on valves. And so, you know, I'm not as directly, but our group, the Michigan Anticoagulation Quality Improvement Initiative, has looked at, you know, aspirin, concomitant aspirin use for patients with mechanical valves, which were excluded, you know, for all the studies that I presented here based on the recommendations at that time. But again, there's been this shift away towards, you know, this being a universal, you know, truth that everybody with a mechanical valve needs concomitant aspirin therapy. So it's definitely something, you know, in practice, you know, what I've seen is, and I was actually recently talking about this with Dr. Barnes, you know, is that, you know, a lot of the patients that I follow that have, you know, mechanical valves, a lot of them still are on anti-platelet therapy. And so, you know, should these patients be, you know, candidates for de-prescribing or not is something I often, you know, mention to their, you know, cardiologist, or I make sure that they're following up with their cardiologist to address based on the recent guideline shifts.
We might have time for one last quick question, and I'd like to just maybe touch about NSAIDs. And you know, a lot of our patients, they got to take their Advil in order to get through the day, and so you know, alternatives for patients with NSAIDs. Arthur, I know you are kind of have like a thing about NSAIDs. Oh
yeah,
boy.
I mean, certainly we can let the other fellows speak on this, but what I will say is NSAIDs are not safe drugs, especially in anticoagulated patients, and there's almost always a way to simply not use them. Again, this is not new. If you go back to even CHEST 2012, there was a statement of drugs do not use with anticoagulants, and guess which one was the top of the list? NSAID. so that I'll let Jacob and Jordan address this issue. But what I often see is folks will say, "Well, I discussed the risk, and that's where they end it." And there really should be much more of a soapbox with regard to NSAID use in anticoagulated patients. Jacob and Jordan, thoughts?
Yeah, this is something I commonly encounter in practice. I always caution patients. It's amazing how many, combinations of risk factors people can pile up with, where they're, kind of binge drinking on the weekend, and then they've got the NSAIDs that they're slipping in there. And, my experience has been that when you really sit down with people and kind of explain this risk and what major gastrointestinal bleed could look like for them, they kind of agree to, kind of avoid the NSAIDs to the extent possible. And of course, if it's going to be used, the side effects are often dose and duration dependent. So, minimizing the use and trying to optimize the other factors if it's going to happen. But, I do have some patients that will even send me messages like, "Oh, I've started taking ibuprofen again, even though I know I'm not supposed to, asking for advice on this." But so anyways, I think, Jacob, I don't know, if somebody's going to be doing it often, that's also raises, my question about adding, GI prophylaxis if they're doing it despite recommendations against it. But I pretty strongly recommend against it for my patients.
Yeah, certainly GI prophylaxis would be appropriate in that setting. Like alternatives to consider are, Tylenol, obviously, topical NSAIDs, capsaicin, coxibs, are like Celebrex is the other thing to think about. There's a lot of controversy around the cardiovascular risks there, but they are lower in terms of the GI bleed risk. If you put a coxib together with an aspirin, you're sort of nullifying that risk, so it's not, you don't get a lot of gain in that setting. But that's another approach to think about.
Excellent. Thank you so much. So rule number 1 is don't use NSAIDs. Rule number 2 is don't use NSAIDs. And rule number 3 is if you have to rip the NSAID out of their cold dead hand, put them on a PPI. Gotcha. Excellent. Thank you. So I want to thank again our speakers, Jacob and Jordan. Excellent conversation here. We had nearly 600 people participating in this webinar. If we can go, and thank you again to Andrea, my partner in crime, co-moderating this. You can go to the next slide for me there, please. So also wanted to talk a little bit about the webinar. So as you know, we have chairs that assist with choosing these topics and finding speakers and moderating these talks and helping with the panelists. And Jeff Barnes and Deb Siegel have done an incredible job over the last couple of years, and they have stepped down from that role within the AC Forum, although they're still involved with the organization. Myself and Andrea are like a rash. You can't get rid of us, so we're going to remain on this. But we also are going to be welcoming Gene Connors, Jory May, and Naomi Yates as our new webinar co-chairs. So looking forward to working them on future webinars. Next slide, please. We also are announcing our new shiny YouTube channel, the Anticoagulation Forum. Currently, the historic webinars are posted on there, and new webinars will be posted on YouTube. So you can now share and like and do all that stuff that might turn me into an influencer if I ever decide what those are. Next slide. Just a reminder about the Centers of Excellence. Encourage you to take the assessment, become a Center of Excellence, get involved with the Innovation Circle once you pass that, and don't forget that it's an incredible resource center for all. You don't have to be a Center of Excellence to use it. We have incredible resources, some of it in original content, some stored important papers and documents, and of course, the very popular online literature update. And now we're doing rapid recaps where we even drill it down even more simply for you. Next slide. We're also announcing that the next virtual boot camp is planned for October, mid-October. Here's some information here, and they are now open to registration. So consider joining us at a boot camp. And then next slide. The trained residency is also the AC Forum is funding the development of new PGY2s and thrombosis and hemostasis, and applications are now open for that program. Check out the website or check out the QR code there at the bottom of this slide to learn more about setting up your site for a PGY2 and thrombosis and hemostasis. Next slide. And as always, I'd like to thank our corporate sponsors, all of these fine folks that help us put these on and do what we do. And at that, we will end the webinar. Thank you all so much for your attendance, and we hope to see you at the next one. Thank you.